Inhalers are most commonly used devices for all forms of medicines, whether it's beta agonist or corticosteroids, and you can see these are the common relievers: budesonide for metrol or dexamethasone for metrol. These are the common inhaled steroids which are used as single inhalant for maintenance or reliever therapy in moderate to severe asthma. Similarly, inhaled long-acting beta-2 agonists with ICS should not be used in reliever monotherapy in stable asthma. This is one of the recommendations for stable asthma. So, uh, a reliever is one, then controller. In addition to as needed reliever, inhaled corticosteroid as preferred controller therapy. So, in management, we see reliever, controller, and it is emphasized that the inhaled corticosteroid should not be delayed. So many times when you utter the word of steroid, patients are, you know, they ask questioning, why I need steroid, whether it will have side effects, whether I will be always dependent on the inhaler or something like that. I do not want to use inhaler kind of things, but we have to overcome this, barriers, arguments, and of the patients, and we have to counsel them appropriately. And dose of inhaled steroids should be considered appropriate, and long-acting beta-2 agonist should not be used as a controller monotherapy without inhaled corticosteroids. So many times, as we see in practice, we see patient using uh, uh, when the symptoms are aggravated, patients are only using, so for example, Asthalin inhaler. Now, what is said that when the symptoms are aggravated, for as a controller, you always need steroid along with you know beta two agonist. So we have to understand that managing inflammation through inhaled corticosteroid is very very important in managing the underlying pathology, which is inflammation. So management is inflammation is most important part of asthma management because beta agonists will have bronchodilator effect. It will relieve temporarily, but unless the inflammation is settled, patient will not have long-term relief. So it is important to understand uh, these things. So similarly, leukotriene receptor antagonist and add-on can be beneficial in patients with seasonal allergic rhinitis or asthma. So patients have seasonal allergic rhinitis. Many people will have seasonal allergic rhinitis, which presents as repeated episodes, recurrent episodes of sneezing, cold situation, and many times people or patients may confuse or perceive these symptoms of allergic rhinitis as common cold, but it is not cold or infective, entity. It is mostly allergic rhinitis, and it is a different clinical thing. But for us also, and from the patient perspective also, it is very important to understand uh, the entity of allergic rhinitis, because it is many times it is managed as common cold. Allergic rhinitis is different from common cold. It is allergic, and to give relief such patients, this is a different approach because again there is local inflammation in the nose, nasal mucosa, and that has to be relieved through not just anti-allergics or a dose of cetirizine or Allegra, but also through nasal sprays of spray in form steroids in form of sprays for a relatively longer duration of time, and then patients are relieved for considerable duration time. Otherwise, every time they are exposed and every week they will have symptoms, and this is many times uh, con- you know occurs in simultaneously with patients who are allergic, because allergic rhinitis and allergic asthma process are interlinked. Not in all patients, but these are often interlinked. Uh, Then other agent is tritropium, maybe use an add-on therapy on patients. How to remember all these devices and medicines? I'll discuss it separately towards the end. So I'm just talking broadly about the uh, group of medicine. Number one is inhaled corticosteroid. Number two is beta two uh, agonist, leukotriene receptor antagonist. Then we see inhaler in form of tritropium. So these are all the common drug groups which are used, which are available in market and products in various formulations. I'll discuss about them later. And then, if with all this, if the patient is difficult to control, if the symptoms are not relieved, the patient is not stable, then the patient has to be referred to a hospitalist or a respiratory physician for specialized intervention, or maybe hospitalizations such patient may require.